Matt, why don't we go ahead and let you do a quick little introduction of yourself, doctor, and we'll go from there.
Yeah. No worries. Okay, hi everyone. My name is Olivia Leslar. I am an Australian medical practitioner. I became a digital nomad about 3 years ago, and so now I consult to clinics and companies in the US, London, Spain, Singapore, and Australia still. I am the medical director of functional longevity medicine at a brain center in Sydney. Um, where we do connectomic mapping of the brain and then personalized transcranial magnetic stimulation. And we use neuroplastic adjuncts to sort of take advantage of that neuroplastic window after TMS. So hyperbaric oxygen is one of them. We also do photobiomodulation, visualization therapy, cryotherapy, fever therapy, peptide therapy, nutritional ketosis, and I also use therapeutic carnivore diet. Anyway, it kind of got me interested in sort of the left field stuff. And so I kind of play in that intersection point, basically between sort of longevity, biohacking, functional medicine, and now quantum medicine as well. If you don't really know what quantum medicine is, it's sort of more that kind of subcellular bioenergetics, biophysics of especially the mitochondria. So we're talking about, quantum tunneling of electron train, of the electrons through the electron chain, blah, 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 in the mitochondria. As far as academic credentials go, I am a faculty lecturer with the Geneva College of Longevity Science and also a senior lecturer with the National Center for Neuroimmunology and Emerging Diseases in Australia. And I'm currently in the process of becoming a lecturer with Georgetown. Um, I do a lot of different things, basically. I guess it's because I have ADHD. But yeah, so I'm happy to sort of answer any questions that I can. I wouldn't necessarily call myself a hyperbaric expert, but I've been in the field and playing around with it for about 6 years or so. And count some of the experts in the field, like Jason Sonners and Scott Scher, and um, as good friends. Yeah, is that good, Brian? Or
That's
who
fantastic.
am I
Yeah.
speaking to? Are these clinicians or practice managers?
So it's going to be a variety. I think that's actually here on the show. So as you know, we work with Trevor King. Trevor King runs an educational webinar, and a lot of the folks that have purchased from him, we offered a physician-led question and answer. And
Yeah. Yeah.
Okay. This is a Zoom Amina. How do you get it? How do you get rid of this? Okay, I was in a Zoom thing.
Don't you love modern technology? Okay.
as long as you're okay to be muted, it's a great thing. Um, but yeah, I believe we met in Denmark in Copenhagen is where we first ran paths with you. Jacob Rogers, our CEO and founder. We met at a dinner, and it's just been amazing since then. As we basically run all the products that you have in your clinic, and we hit it off as far as like being able to consult with you on our new opportunity to open locations. And so it's been fantastic partnership since we started, and we appreciate your willingness to come on this and answer some questions. I think maybe the easiest way to start this and get the flow going so people can think about it is let's ask some of the questions that people have sent in, and then we'll go from there and see if anybody else has other questions. But like the first one that was submitted, it was submitted by Richard, I believe. Is there a maximum amount of usage per day or per week for safety reasons and to help achieve some initial visible results from using the HBOT system?
Okay, so in the literature and in clinical practice, we generally speaking don't do any more than 2 sessions per day. And there's a good sort of air break between those 2 sessions. So the you would be sort of giving the patient a break of at least 1 to 2 hours before doing two 60-minute sessions. To be fair, we actually meet the patients where they are. So if they can't afford the time to be at the clinic, we just do one long session. There is maybe some signal in the literature that this, two short sessions, which is like considered an intermittent pulse, may produce like a stronger biological signaling than one continuous exposure. But both approaches are used clinically. And I don't think that there's such overwhelming evidence for one over the other that you would definitely do two shorter pulses. Because each session is generally speaking 60 minutes. And I know that lots of clinics are trying to go for that 90-minute stint as well, in part to gather the data on their own population, right? But so that would still give you 120 minutes in a day. And if you are doing 120 minutes, you do need a short air break in between anyway. So that would wind up being 2 hours and 15 minutes or something like that. If you can, two shorter pulses, also then you're able to check how a patient feels. Because at the end of the day, don't forget that depending on how much pressure you're using, generally speaking, you are going to increase oxidative stress in the patient. Like oxidative stress is oxygen in the system, and you're also firing up the mitochondria. So you're going to have more mitochondrial output anyway, which means you're going to have more reactive oxygen species. So we always supporting the patient walking in that they have enough fuel in the tank, enough antioxidant capacity in their system to buffer with that increased oxidative stress. But just make sure that your patients aren't taking in IV or orally antioxidants around the hyperbaric oxygen, because you're just going to blunt the effect of that increased oxidative stress, which in part is actually obviously depending on the patient's issue. You actually do want that. You want a certain amount of oxidative stress, whether it's to stress a cancer cell or to stress bacteria because it's an infection, or to stress the bone marrow to increase stem cells, for example. You just want the body to be replete so that the body can buffer itself. But we want to artificially be buffering the patient because you don't want to be blunting the effects. It's
What type of issues or what type of diseases require more time in the hyperbaric chamber versus, say, if they were wanting to do it 2 or 3 times a week? So, are there different amounts of time you should be spending in the hyperbaric chamber based on the issue you're trying to solve?
Yeah, actually, because there are so many protocols out there, I'm sure that maybe people would find it handy if I actually put together like a short sort of, history of mechanisms of action and then kind of the protocols that seem to be out there. Um,
That'd be
there
fun.
are two types of, yeah, okay, no problem. I'll do that today sometime. I'm going to be traveling anyway, so I've got 2 hours at the airport to kill. Um, so there are the investigational protocols which have got good evidence because it's part of a study. And so that's mostly the work of Shai Efrati in Tel Aviv. He's at Segal Medical Center. So that's like he's the best known researcher when it comes to HBOT. Like he went to town during COVID, and was the one that came up with the hyperbaric oxygen protocols for long COVID. So there are those kinds of protocols, but so understand though that his population is the population that are around Segal, right? And then there are the protocols that are gleaned from the different places that are doing hyperbaric on a regular basis, because a lot of this is from first principles in that how hyperbarics work, right? I.e., that we are increasing saturation of oxygen into the tissue and into the plasma to a point where you don't need red blood cells to carry the oxygen anymore. You're increasing oxidative stress. You know that the more pressure you're putting on the system, that the more oxidative stress you're probably going to be inducing. You know that when you go from high pressures or deeper dives to a regular pressure, so 1 ATA, which is where we are now, right? That you actually almost get this hypoxic effect. And that these sorts of challenges to the system is what's going to make the system a little bit more flexible and induce the, VEGF or HIF or any number of the 8,000 genes that are upregulated or modulated with hyperbaric oxygen. So it's actually AI is going to save us when it comes to hyperbarics for sure. But there are lots of different protocols. Okay, so what was the question? Oh yeah, the different
I,
protocols.
I,
The different protocols.
protocol for like,
Okay.
say, is it similar for Lyme disease versus something that is not as chronic as that? So maybe like if you're trying to save inflammation in a joint and my knees are sore versus like a Lyme disease, which is very long, chronic, drawn out disease.
Yeah. Yeah. So usually sort of infections or so, you're sort of going slightly higher pressures. Um, 2 to 2.5 ATA. In clinic, I rarely see anyone going above 2.7, 2.6. And that's of course if you have those massive sea crests or uh like the big ones, right? So but generally speaking about 2 ATA is where you're at. How long your sessions are, sort of standard clinical sessions are about 60 to 120 minutes because oxygen toxicity risk does rise with like prolonged or repeated exposures, especially at the higher pressures, which is why we kind of pull back a bit to see how the patient is responding. Um, there are some clinics that will actually test things like HSPs, heat shock proteins, which might come from like double whamming a patient with heat therapy plus hyperbarics. Or patients might, some clinics are starting to use those mitochondrial screens that are coming out, like me screen, to see how that mitochondria is changing using a short block, maybe 1 or 2 weeks of hyperbarics, and then to see how the mitochondria is responding, because we know that hyperbarics also increases things like telomere length and obviously mitochondrial activity. The one thing that I have to say that I feel anyway, and I'm sure this is a bias. I mean, we're all biased with what we do, but I've never been a single modality person. So I like to stack my modalities. And if you're going to be playing around with hyperbarics, I usually make sure that there's other things in the mix to assist the mitochondria. So I
Okay.
like stacking red light, ubiquinol, spermidine, which helps with autophagy in the cells, making sure that the patients are really grounded. So getting out there, putting their bare feet on ground, because we need more of those electrons, because in the mitochondria, you're quantum tunneling electrons through the electron transport chain to then quantum tunnel protons into the intermembrane space. You need that concentration of protons in that intermembrane space to drive down the H plus hydrogen, the protons through the ATPase. And so, you can power up the mitochondria all you want. If there are bits and pieces missing, it's going to be like roadblocks. So the protocols actually aren't as diverse as you would think, only because like essentially it's got a slightly antioxidant effect or an oxidative effect, right? So lower pressures like 1.3, 1.4, 1.5, especially since those tend to be the really, really mild chambers, they can almost have an antioxidant effect. It's a little bit like vitamin C. The dose makes the poison. So at lower doses with vitamin C, it's got this antioxidant effect. Higher doses, it's a pro-oxidative effect. And we actually want that pro-oxidative effect in things like cancer, exactly the same as with hyperbarics. So it depends on the issue. So with like traumatic brain injury, for example, when there is already a lot of oxidative stress in the brain, you kind of want to go slow, start low, lower pressures just to help the body get more oxygen to assist with healing. You're not trying to use an oxidative effect of high pressure HBOTs with someone who's got acute brain injury, for example. But where someone has got anaerobic bacterial infections, wounds that aren't healing, those sorts of things, then you kind of want higher pressures up to, 2 ATA, because you want that pro-oxidative effect. Someone who's got mitochondrial, like they've been chronically ill and their mitochondria is sick and toxic and stuff like that, and you want to increase that lymphatic movement as well, then about 2 it tends to be sort of where we're sitting. So generally speaking, you'll actually find that a lot of the more medicalized, in inverted commas, medicalized protocols do sit around the sort of 2 mark, 2.2. But I think most people tend to start low and then go slow to see how their patients are, the 1.7s, 1.8s.
Yeah, and just to set the stage, so most of the people that attended um, Trevor's webinar and that are here, they purchased the Ultralux Comfort Plus chamber. So the Comfort Plus chamber is a 1.5 ATA, and it's a soft shell that is the beginning of what you're speaking of. So yeah, it's not as high.
Okay.
Um,
Yeah. Okay.
but
So the hard shell chambers at like 2.5 ATAs and all the rest of it, they're like more in a clinical setting, right? When you're dealing with like cancer and that kind of thing. So supportive stuff. So in my clinic, we have a soft chamber. We have a soft chamber that takes us to base 1.7, right? And what I deal with most of the time is brain injury. So neurodegeneration, TBIs, and then post-stroke rehab. So in this case, what we're trying to do is just push in gently a little bit more oxygen to assist with the healing process that is not driven by an anaerobic bacteria. That's not driven by a bacterial infection, that kind of stuff. Because at my clinic, what we're trying to do is kind of like hold the patient a little bit to give them a bit more bandwidth so that the body is able to do what the body wants to do, and that's heal. So that's where these sort of lower pressures can be very handy, because even at 1.3 ATA, you're already increasing oxygen in the blood by like to 60% or so, right? And so it's and don't forget, using a pulse oximeter is not indicative of how much oxygenation is in the plasma. It just shows you what the oxygenation is of the red blood cells. But when you're using pressure, pressure increases oxygen even into the plasma and to the soft tissues. So that's more supportive care, more sort of antioxidant effect of the hyperbarics is at the lower pressures, so below 1.7, 1.75.
Perfect. You mentioned before that you love to do other modalities with it. So you like to double dip basically with other wellness benefits, which is great. One of the questions was like, hey, are there any other known supplements or prescription medications that may cause issues? So not just like that are good for it with you there, but is there things that they should avoid taking when they're during HBOT sessions?
Yeah, definitely. So you got to be very careful with chemotherapeutics. Bleomycin, for example, which is a chemo drug that can actually increase pulmonary fibrosis in hyperbarics. Um, Doxorubicin increases cardiotoxicity. A lot of people, well, not a lot, but in LA, we had a lot of patients on antabuse. So that's disulfiram. And that basically stops you from drinking alcohol because you feel sick with it. And that can actually increase seizure risk when you're, so there's like a bunch of drugs that I have. Those are the three that come to mind. But mostly it's sort of those that change seizure threshold and the chemotherapeutics. And then, of course, as I mentioned before, you want to be careful using like high dose antioxidants because they're going to blunt that effect of that oxidative hormesis. So, hormesis is where you give someone a short-term stress and you're going to get long-term benefits out of it because you're upregulating certain genes, because you're going to make the system a little bit more flexible, for example. So hormetic stress, oxygen is a hormetic stress, even at 1.3, 1.4, 1.7 ATA. Very mild, but it's there. And so you want to be careful with those high dose antioxidants. And then, of course, you also want to be careful with pro-oxidant agents because like high dose iron, like I don't let patients go into a hyperbaric chamber within sort of, I say a week, but I know other people have different protocols, but of having iron infusion, because this can actually amplify the reactive oxygen species in a counterproductive way. So trying to make sure the patient is replete, but that you're not actively augmenting their oxidative antioxidant kind of status with all these supplements and drugs around the hyperbaric session. Now we're doing, I know that some people have been talking about doing IVs in hyperbarics, but you need a whole bunch of equipment in the hyperbaric chamber when you do that, including because you need to be able to push the fluids in a particular way, and like the how quickly the fluids run changes when you're hyperbaric. But I've never been in a clinic which actually did that. I know people are talking about it, but I tend to sort of hyperbarics, and then stacking protocols around the hyperbarics is kind of what I've been more prone to do anyway. It's just trickier when a patient is in the hyperbaric, and if you've got needles in them or whatever, if something goes wrong, it's a lot harder to sort of decompress and get in there. So hyperbarics in and of itself, the actual session tends to be like a sacred time.
I get it. Yeah, and that's how I do it too. I love it like that, where it's my sacred time. I get to sleep or I'm going to read by
Yeah.
myself.
With lower pressure chambers, they do allow electronics in there, for example, right? But I always say to my patients, I don't allow that. And I use the risk of fire or whatever it is as an excuse. But actually, to be honest with you, I use it as a guaranteed way that patients decrease anticipatory anxiety about their phone, right? And because they know that they're stuck in the chamber for an hour and they have no access to the phone, they just drop into a parasympathetic state because this is their hour that they can't have it. And so then they wind up meditating or reading or something instead. But I know then it's 1 hour in their day where they don't have their phone.
Very smart. Very smart. Speaking of that, does being in ketosis allow the HBOT to work more effectively, or does it have any effect on that being in ketosis?
Yeah. So in preclinical research, there is definitely this synergy of ketosis and HBOT. I'm pretty sure it's particularly like in cancer and neurological conditions because ketones increase that neuronal resilience against oxidative stress and excitotoxicity and stuff. But I've never seen it in low pressures, but theoretically it can lower the seizure risk, right? Hyperbaric. Hyperbarics can theoretically increase seizure risk, and ketones and ketosis can lower seizure risk. So it's actually very helpful for that. So I guess there are two types of nutritional ketosis, right? You can do it through ketogenic diet, or you can do it because you're actually taking exogenous ketones, and both of them enhance hyperbarics like mitochondrial and neuroprotective effects. I guess if you're experimenting, I don't think I have enough volume in my own clinic to say definitively, but if you're experimenting, you'd kind of want to look at like mild nutritional ketosis. So that would be, I guess, 0.5 to 2 millimoles of per liter. I don't know what units you guys use, I'm sorry, of the BHB. So your beta hydroxybutyrate. And that's kind of like, I would think, a safe range to like test out and improve tolerance and like the cellular benefits. Yeah, so I think definitely nutritional ketosis can enhance hyperbaric effectiveness.
Thank you. One of the next question I have is, do you have any advice on using PEMF, so pulse electromagnetic field therapy in conjunction with HBOT?
Yes. So of course not at the same time. But I love pulse electromagnetic field therapy for sure. They work in different ways depending on who you speak to. They have a particular passion for one thing or another, specifically about the PEMF. So we're bioelectric beings, right? If we did not have electrical signals running through our body, our brains wouldn't work. Like we accept that the brain is just electrical signals, right? That's why white matter is white, because it's fat, because you need to insulate the electrical highways of the brain. But for some reason, us doctors, and I apologize profusely for what my profession has done, but us doctors just refuse to sort of look at the sort of bioelectrical aspects to the human body outside of the brain, except when it comes to the heart, let's just say, because of electrical conductance, of course. But at that cellular level, if you weren't able to have a good membrane potential, so if you didn't have a good resting membrane potential, it affects how the ion channels and the receptors move molecules up and down, in and out, and so on and so forth. So pulse electromagnetic field changes the potentials, the membrane potentials, for example. We know that when you're sick in cancer cells and all the rest of it, the membrane potential goes way out, right? You can actually tell if a cell is unwell just by doing electrical impedance testing. And actually they did it, this is decades old now, but they actually did in chronic fatigue syndrome patients, like knee electrical impedance testing, where they put, an electrode on one side of the knee and an electrode on the other side of the knee to see how quickly the electrical signal runs through. And it's completely different in chronic fatigue syndrome patients as opposed to regular people, because the cell is just not conducting electrical signals appropriately or properly. And so, as you can imagine, the mitochondria, which runs on electrical signals and runs on electrons and protons, it flags. And so I love pulse electromagnetic field for that. And also we are consistently in environments which are non-physiologic, right? They're non-native. Electrical signals and electrical pollution, and very few of us are exposed to good quality Schumann resonance. So Schumann resonance is that background frequency, that background radiation of a particular frequency from the Earth, and that's at 7.83 hertz or so, and that goes right up to like the ionosphere. And if you go on YouTube or whatever, you'll see that people will have like Schumann resonance music, for example, to sort of give you that the frequency that we should be exposed to on a regular basis. But we have so much frequency pollution with 5G, 6G, 4G, Wi-Fi, all that kind of stuff. So I'm a huge fan of pulse electromagnetic therapy.
Would you use that before, or like how would you use that in conjunction, or how would you stack that if you were to use it in conjunction with HBOT?
I probably use it after HBOT, because so HBOT gives you you're saturating cells, you're saturating the soft tissue, interstitial fluids with oxygen, and then you're using pulse electromagnetic field, which then is able to utilize the oxygen whilst it's like changing the electromagnetic fields around the different cells and membranes. So I would probably do it that way, but I can't actually see any reason why you couldn't do it the other way around, to be honest with you. Generally speaking, the only thing that we're like sticky about is ending, because if you're presumably you're in a wellness center or clinic, you would usually have PEMF, HBOT, lymphatics like Normatec, Stendo, or Flowpresso, sauna, some sort of heat therapy, and then cold therapy, right? So whatever it is, we usually say, yeah, there's evidence for one way or the other, but I wouldn't say that there's hard evidence for anything except ending on cold. Most patients feel really good ending on cold because of that rush of, cold shock proteins. It tightens everything up, the cells, and they feel just quite energized with the endorphins that run through your system after a cold plunge or a cold exposure. So we always just say, that's probably the one thing that we stick with, and that's ending on cold.
Cool. Good deal.
Uh, Questions. 7 titanium plates. Sorry, dude. Pins and screws in my upper back from a spinal fusion due to 2 large lesions that were eating away half of my spine after diagnosis of multiple myeloma. Am I safe to use HBOT? Yes, you are. Absolutely. Yeah, that's not a contraindication. Yeah, no, you're safe to use HBOT.
Cool. I am going to, seeing as how we've burned through all our questions, unless there's something that you are just itching to speak about with HBOT and that you would wish that everybody would know. One of the things that actually I will bring up. So we have this 1.5 chamber, it's a sit-up chamber that people use in their homes, and they have a grounding mat in between. We have a lot of questions based on specific treatments. One of the things you mentioned earlier is that the protocols are very similar across the board. what is the recommended time from a physician that is like, hey, this is a pretty standard protocol that you would operate on, not just the times, how many times a week, but you've already mentioned that, but like is 60 minutes the go-to time? Is it 120? What's the standard for like all the protocols that are out there? Because there's so many different things people could be attacking that we get asked about that like, hey, this is the one protocol that if you're going to stick to it, this is great.
60 minutes.
Okay.
That's pretty standard, I would say. It obviously it's cancer where you see possible sort of like 120 minutes and all the rest of it, but that's very specialized. And even I'm not playing in that hyperbaric for cancer space. So the hyperbarics that I use are for, like I said, my brain center. And then outside of that, it's mostly for biohacking, wellness, mild cognitive stuff, which is we're seeing a lot of that, not from traumatic brain injuries, but from
The concussions,
hormonal
right?
shift.
Like if somebody gets a
Hmm?
concussion, like that's that we get asked that a lot. Like, hey, my son's in football, he got a concussion, or he's in soccer. What's the protocol for somebody that has a mild concussion?
Wow. Okay. Let me see. Mild concussion. I actually, my own document here that I have, very happy to share. I'll put it together so it makes more sense for you guys. But generally speaking, okay, so the studied concussion protocols that we have are 1.5 ATA for 20 minutes, 1.75 ATA for 20 minutes, 2 ATA for 10 minutes, and then as many as 2 sessions per day but they're very small, as you can see, because we can't see inside the head. So we don't know exactly how much inflammation there is. And what we want to do is not push them so far that we make it worse,
Yep.
because you also don't know one patient to another how much antioxidant reserves they have in their brain, how many workarounds their brain has already. So someone who's got very strong neuronal connections, they may have the same concussion as the next person who doesn't have as many connections, and the person with more neuronal connections, they're going to do better because they've got more workarounds, right? So it really depends. That's why we do much shorter sessions, much lower pressure sessions, because you're trying to see how they're responding. It's kind of a little bit like hormone replacement, you know? People love to do like tests, Dutch tests, blood tests, and those can be very handy, of course. Like you really should be getting some sort of baseline, some sort of understanding of pinpoint in time on particular days. Let's just say a woman, day 21, whatever, where she's at. But because you're not there with her 24 hours a day, you don't know how she's responding to those particular hormones, right? So if you give her a list, though, of, okay, this is how you're going to feel with estrogen, if it's too much, if it's too little, progesterone, and then she's able to adjust her dose ever so slightly, because you're probably going to give her like a estrogen gel, for example, so she can, if she feels like her boobs are too swollen and painful, she's going to cut back a little bit on that estrogen dose. You got to give patients a little bit of agency. So when we start low and go slow, when a patient comes out, you can observe them and you can ask them how they feel. And if they say it's just like hot, or it's too much, or lights are too bright, sounds are too loud, like you can just see that they're a little bit agitated, you got to pull back, right? But if patients can handle it, sure, great. You're going to increase your sessions to 40 minutes or whatever it is. So that's acute injury. Um, then you have like chronic TBIs, right? In other words, sort of more than 3 months of symptoms, that you're going to have 40 to 80 successive. See how big the protocols are. You're going to look at like 40 to 80 successive sessions at 1.5 ATA, right? About 60 minutes each. Can be done twice daily. I've except for the hardcore hyperbaric centers, I've never worked with a clinic or in a clinic that does more than one session a day, in part for um, logistics and stuff like that. Um, and yeah, so if there are no improvements to that, um, or rather, if you're checking at treatment 20, kind of where we will sort of see, you're doing the battery of cognitive tests and stuff like that. There's no improvement. Then we increase to 1.75 ATA for 60 minutes apart.
Okay. Good deal. What about diabetes? Switching gears a little bit. So with diabetes, is it used to treat diabetics?
Yeah, you got to be a little bit more careful with diabetes because you're changing the mitochondrial function, which then means that you're actually changing insulin sensitivity. Patients have to get into a hyperbaric chamber sugar relate, like they must have eaten, because you can actually drop their sugars and they can get hypo. So it's very individual as well. Like there are so many different, inverted commas, different types of diabetes. It's a spectrum. Everyone talks about type 1 being autoimmune and then type 2 being lifestyle driven. That's true, but it's how so? Like, is it because of excess sugars? Is it because of a GLUT4 issue? Like, how is it because of how the sugars are being brought into the cell? Is it because your pancreas is not able to produce um, insulin as efficiently? Is it because you have a liver dysfunction? Like diabetes is actually so much more complex than I was led to believe when I was in medical school. Um, and then you'll actually find that it could also be because there is a cardio carbohydrate intolerance, right? Because or a lack of metabolic flexibility, which then presents as diabetes, but in a particular way. We know that
Mm.
not all sugar receptors are the same, right? Sometimes sugar receptors in the brain can act differently to sugar receptors in the body. How big are your muscles, right? Because muscles are sugar sinks. So someone with very big muscles and a man is going to, their sugars are going, or their insulin is going to respond differently to a hyperbaric chamber than to me. I'm 5'3" and 50 kilos. I don't know what that is in pounds, but I'm tiny, right? I'm going to respond very differently. So I'm trying to think what the protocol is for diabetes, but it also depends on what you're trying to achieve. A lot of the time that I've dealt with is most patients with diabetic wounds. So that's different, obviously, than insulin sugar modulation.
You mentioned something earlier that before we actually, we'll ask this question. Somebody asked us, like, what about the use of castor oil or DMSO or and when in the chamber?
I love castor oil. I'm gonna guess castor oil packs, for example, are very handy. Castor oil in the belly button, sitting there for a little bit. I actually, funny you say that because this is a few years ago now. I actually had a castor oil pack over my lower abdomen whilst I was in hyperbaric chamber. I hadn't even thought about it, to be honest. It was a low pressure chamber, but I was trying to deal with women's issues thing. So castor oil, yes. DMSO, that's a slightly different kettle of fish. So what kind of chelation or what kind of detox are we trying to achieve here? And then how much before and after? I actually haven't played around with DMSO um, protocols myself around hyperbarics. I'll have to ask someone with more experience. I'm not sure is the answer for that.
No worries. I was getting into what you said earlier around biohacking and some of the uses, what you've seen within that community. That's what we get a lot of people obviously interested in this in home use when they're trying to biohack and increase their wellness. What are some of the benefits of using HBOT in that type of environment where it's not specific for an illness, but they're just like, hey, I'm just trying to improve my wellness and longevity.
Yeah, you've disappeared. Oh, there we go. Okay, wow. So it is, we all know increased oxygenation, like, is going to be helpful. Full stop, end of story. Okay. And so this is definitely one of those times where you're going to get increased oxygenation of your soft tissue, of your plasma, of your different organs. And it's independent basically of how you're breathing. Because to be honest with you, from a functional medicine perspective, you'll actually find that most people have got dysfunctional breathing, which is why, in part, like James Nestor's book, or Patrick McEwen's book, The Oxygen Advantage, were so popular because it makes such a radical difference. And then the rise again, right, of breath work, it was also another feather in the cap of just oxygenation in general. So hyperbarics, if you can afford to have a chamber, good for you, because it absolutely, I think, is a staple of the biohackers protocol list. General well-being, definitely, you're modulating stem cells, you're modulating VEGF, so that's going to be your vascular inducible sort of growth factors and stuff, which means that you're going to have increased repair. And we always see that patients, especially in the literature, and so most of my patients are very sick, not sort of wellness type people, but people always say that when they come out of the hyperbaric chamber, they feel like they've got more clarity, because at the lower pressures, there's an antioxidant effect, or can be an antioxidant effect.
Awesome. With that, I'm going to open it up and unmute everybody. If let's not all talk at once, but if there's any outstanding questions before we let the doctor go, let's see if we can. I'm going to allow you guys to unmute yourself. So everybody can unmute themselves now, and let's see if there's any additional questions before we let the doctor go.
Yes, I have one.
Go ahead.
Hi.
I've got real bad neuropathy, and that's what I'm hoping this will help a lot. Is there a standard protocol or anything? I especially got the staining from the iron deposits in my lower legs.
Yes, there are neuropathy protocols. Let me just pull it up to make sure I'm giving, yeah, neuropathy. Okay. So far, from what we've seen in the literature, it is a difficult one to treat. But there has been some success at 2.0 ATA for 90 minutes for 20 to 40 sessions. I would definitely, I mean, I'm not sure what your protocols are with regards to your neuropathy. Do you know why you have neuropathy?
From cellulitis. It's
From
damage
cellulitis.
left over
Okay.
from that.
Left over. In other words, the inflammation is gone, infection has been
Yes.
treated, etc. Awesome. Okay. So we know that generally speaking, nerves regrow 1 millimeter per month, right? And that's if, I'm sorry, I don't know what that is in imperial, but 1 millimeter metric per month. That is sort of the standard that we say to patients in hospital, in clinic. But that's if all the chips, all the stars align, which means that your B vitamins, your choline, your amino acids, your fatty acids, and your oxygenation are right. And I suspect that in you, probably that is the case. So the only other thing is going to be bioelectrics. So pulse electromagnetic field can be helpful. I don't know if you've tried it, because some people describe it as being a little bit on the painful side. Just start super low, right? And the other thing would be to, you'd be surprised by this, but if you're actually using is the neuropathy in your hands or your feet, both?
No, just my feet, my legs, lower legs.
Okay, your lower leg. Okay, so if we're looking at just legs, because if you think about it, your feet are further away from your heart, and the oxygenation actually gets worse down there. Lymphatic flow is worse down there because it has to fight against gravity. So using something like Stendo or Flowpresso, which is lymphatic kind of drainage assist, can also be very handy, because you want to be taking away the toxic metabolite and constantly be flushing your lower legs with nutrients. So oxygen, yes, but nutrients is the other one too. And then, of course, the regenerative therapies, so your stem cell therapy, your PRP, exosomes, even peptides. But I actually have success. I have had success with neuropathy. It took a lot longer than I expected. So in my last patient with neuropathy, it took 2 years. I thought it was going to take a lot less than that. But his was induced by actually it was emotional stuff. So he was cleaning out his father's apartment after his father passed away. And so obviously that was devastating. But his father's apartment was full of black mold, which he didn't know about. And he got sick with mold toxicity and he wound up with peripheral neuropathy. Um, and then we dealt with the mold, which I thought was going to make him better, and it didn't. Everything else got better except his neuropathy. And then when we dealt with the emotional side to that, he got better after that. So that's his story. But I feel like neuropathies, whilst complex and complicated, yeah, I've seen in my patient good results, and I know that other practitioners have got good results too. So I want you to know that there's an answer out there somewhere for you.
Will the 1.5 ATA just take longer than you were saying, 2 to a little bit more than 2? Will that just take longer then for the same effect, hopefully?
Yes, yeah. We just want to make sure that we're giving your cells, assuming that your lymphatic drainage is good too, of course, because whilst we can saturate the lower legs, let's just say, right, we can saturate the plasma and the interstitial fluid and the tissues with oxygen. If the metabolic waste that comes out of the mitochondria working harder to repair, if metabolic waste isn't moved from your lower legs, they're just going to essentially reharm cells. So you got to make sure that that lymphatic flow is going as well.
Okay, thank you.
Welcome.
Fantastic. Other questions?
I have a question. My name is Lori. My husband has had a chronic cough for about 14 months. At first, we thought it was due to a chemical within a floor stripper that he was using at work. He's on his third pulmonologist, and they think the first two just wrote it off as asthma or allergies. Now he's on his third pulmonologist, just got a second CT scan, and he has difficulty taking a deep breath. He can't take a deep breath without coughing. Now, we've had the HBOT. We bought it through Trevor King, and he's worked his way up to about 70 minutes in the HBOT. Now, the first time he was in for an hour, he was able to sleep soundly in bed without having to sleep in a recliner, and he slept soundly all through the night. But now I'm wondering, after spending 70 minutes in last night, he ended up coughing a lot. Now, I'm wondering if that is due to oxidative stress on the infection, if he's got a lot of congestion or mucus or bacteria at the base of his lungs, would that be oxidative stress on the disease? Because whatever's down there needs to come up. So he was spitting up more last night and this morning.
So that's a really good question. So does he have do his lungs move like they should? Does he have good diaphragmatic control of his respiratory system?
He can if he thinks about it, but he's more of a mouth breather than a nose breather. So he really has to think it through as far as his breathing habits. Now, listening to his lungs, they were clear. Sometimes he presents with wheezing. But so again, we're on our third pulmonologist to find out. He does have some scarring at the lower base in his right lung.
Okay,
But
so the important thing to know about the lungs is that they are one of your three most important guardian sites. A guardian site of the body is a part of the body where if a bacteria, virus, or parasite were going to invade you, it would usually come through one of these areas: skin, your gastrointestinal tract, or your lungs, which means that these areas have a much higher density concentration of mast cells, or like soldier cells, sentry at the gates, that shoot first and ask questions later. The wheezing is where the nervous system actually closes down the bronchioles, tightens it up because it's afraid that something's going to come in and it doesn't want it to go any further into the lungs. So this is a protective response. I'm going to guess your husband doesn't actually have an active infection. So what he has is active chronic inflammation, right?
Oh.
Yes, because an infection is where you have a bacteria actively having a go, or virus, right? But generally speaking, without fevers, and the third pulmonologist, and they told them that it's, that they kind of like brushing you off it. This is not infection. So infection is off the table. Is inflammation. Inflammation is a protective evolutionary response. What happened, so this is a lot of my work, so I'm a psychoneuroimmunologist. What happens is that when your system, especially a guardian site, is exposed to a threat, a good going threat, it's a case of fool me once, shame on you, fool me twice, shame on me. So the threshold for activation of the inflammatory response is much lower now. So you can look at him sideways and he starts to cough, or he starts to feel like tight in the chest or something like that. In part, it's a self-fulfilling prophecy, right? Whereby his system, his nervous, this is all subconscious. His nervous system is so worried that he's going to get poisoned again, or assaulted, or there's a threat, imminent threat incoming, it starts to cough. But when you cough, 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 and you're not actually bringing anything out, it's scary because you actually wind up deoxygenating, desaturating your oxygen, right? Your system. Then that triggers part of your brain to like be afraid. And then your nervous system gets really worried, and then it drops the threshold for being activated. And so you wind up in this, what we call a neurogenic cough now. So a neurogenic cough is where the cough is actually not in response to a physical threat. The neurogenic cough is actually in response to lowered thresholds for cough activation.
Okay.
What do we do? Hyperbaric oxygen is definitely a good way of making sure that his system is nicely oxygenated. Don't go too cray-cray. 1.5 ATA, 1.4 ATA for 60 minutes, maybe twice a day is enough.
Okay.
You don't need longer sessions or anything like that. That's the first thing. The second is that we're going to really focus on how he breathes, because right now the system is so afraid, it's inducing inflammation in a response to protect him. He needs to prove to the system that he's got this. He needs to breathe nice and slow and deep, using his primary muscles of respiration, not his secondary muscles of respiration. The primary muscles of respiration are the diaphragm and the intercostals. The secondary muscles are these ones which you use when you cough.
Yes.
And all this, that when you use it, actually stimulates the sympathetic nervous system, the fight-flight response. So we're going to have to decrease this use, increase proper usage of the primary muscles of respiration, and we're trying to trick the nervous system into realizing we are okay. Right now, it doesn't feel okay. Right now, it's nervous, it's worried. The other thing that you can try actually, whilst you're doing all this, like none of these are negotiable, basically. So you can actually consider inhaled PRP. We've had some good success with the radiology practice that I work with in Australia. We actually had a patient who had previous lung cancer, who then got a pneumonia in Bali. And because she had a previous lung cancer, she had a cavitation. She had a scar tissue slash hole in her lungs. And her pneumonia, just she wasn't able to kick it, obviously, because of her immune system and stuff. But we did inhaled PRP, and we have radiological evidence to show that the cavitation closed up after.
Okay.
So you can consider that too.
Okay. He did say that he thinks we also have a in-home sauna. So he likes to climb in there at about 155 degrees for about 15 minutes. And he seems to think that that is helps him. He feels better in the sauna than the HBOT. Now, my neighbor is a stem cell research, and he said, go in there 15 minutes and take methylene blue. Some methylene blue. What does methylene blue
So methylene,
How does that
meth
react in the sauna?
so methylene blue is an electron donor. Basically, it shuttles electrons from protein complex 1 through to complex 4, bypassing 2 and 3 in the mitochondria. And it can be very helpful. It's a biohack. Basically, you kind of don't want to be doing a 4, 8, 12. So you don't want to be doing more than 16, 20 milligrams a pop, and no more than 3 times a week or so. It
Okay.
stains everything blue, blah, blah, blah.
Yes.
So that can be handy. The sauna can be very helpful because the three main ways that it does that, that of course it brings on sweating. Sweating is a detox. The other one is that it induces HSP, heat shock proteins. Heat shock proteins are a chaperone protein. They go into the cells and housekeep. They clean things out. And it also induces something called the NRF2 pathway, which is an antioxidant pathway. Sauna is also a sympathomimetic. So it's like an exercise mimetic. Your heart rate goes up, your blood pressure goes up without you exercising, right? And because the air in saunas tends to be a little bit more humid, it actually helps quieten down lungs that are a little bit neurogenically sensitive. Because you know how some people will cough if they're exposed, take a deep breath with cold air or dry air?
Yes.
What the sauna
Yes.
does is that it counters both of that, right? So it just stops the lung from being as reactive.
Okay. Yeah. Okay. I just want to be sure I'm not introducing or implementing too many things at once, because then it's hard to measure what is affecting the progress or the lack thereof.
Yeah. So you've hit the nail on the head. You know, usually we give any new protocol, any new intervention 1 week before or 2 weeks before we add something else in. Methylene blue and sauna is not like it's not a it doesn't counter each other at all, but it's also not like a stack that we go straight for.
Okay. Very good.
Because
Thank you.
yeah, you're welcome.
Yeah.
Well, fantastic questions, and we so appreciate your time today. I know you're all the way across the world, and we appreciate you getting up very early for us. And we just thank you so much for your wisdom and for your guidance and answering all these questions.
You're welcome. Thanks, Brian. Thanks, everybody.
Thank you, everybody. We appreciate you attending. We'll get a recording out shortly. Everybody have a wonderful day. Thanks again, Dr. Lesser.
Bye.
Bye-bye.
Okay.